I'm Chris Horning. I'm a ENT resident at EVMS at ODU. Time of recording this, I'm just finishing up my intern year. So I wanted to talk a little bit about how to evaluate ENT clinic chief complaints to prepare students that are going into their acting internships or sub-Is. I think that there's a lot of resources out there in terms of general knowledge of ENT, surgical videos, steps for procedures, resources for kind of learning more about the pathophysiology of disease, but haven't heard a lecture, seen a lecture about kind of what to be thinking about when you're working up patients for their chief complaint. So I thought that this might be helpful to get you all prepared. I'll talk a little bit about kind of diagnosis and the pathophys of things as we go on, but focus is going to be primarily on what types of things to be thinking about, what types of questions to be asking patients so that you can look as good as you possibly can during your sub-Is. So first thing, important to ask all of your patients if they take blood thinners. You're going to end up seeing a fair amount of in-office procedures being done, and if that's the case and they're on blood thinners, they might not be able to have a procedure. So I've gotten burned on this a couple of times, so I just wanted to make sure that I could pass this knowledge along to those that are going into any surgical specialty that it applies to, but ENT as well. So important for in-office procedures and then also for planning for possible surgery. So let's start with talking about sinusitis, one of the kind of main complaints you're going to hear within the rhinology clinic. So really for all of the chief complaints that I talk about through here, you're going to hear the OPQRST. So just kind of getting a good idea of when did it start, what's making it worse, anything make it better, that sort of thing, which we all learn about in medical school. So as you're asking that, symptoms you're going to want to be asking for specific to sinusitis are the hallmarks of nasal obstruction, purulent rhinorrhea, postnasal drainage, pressure in their face. You're going to want to also ask them if they're having like headache or pain. That in particular will kind of start to maybe steer you away from if they have sinusitis or something else. You're probably not going to be seeing patients with complications or complicated sinusitis in clinic, but always important to ask if they're having vision changes, if they're having fevers, if they're having chills, to get an idea about whether or not they are maybe somebody who needs to go to the emergency department out of the clinic to get evaluated a little bit further. So other questions important, ask if they have a history of allergy. One of the kind of general principles of sinusitis, at least in the past, it's become more complicated as further research has gone along, is that swelling of the nasal passages can lead to inflammation and then start to obstruct the drainage outflow tracts of the sinuses. And kind of one of the general principles of surgery is you have inflammation. Inflammation leads to buildup of fluid behind that inflammation. That backup of fluid kind of acts as like a stagnant pond where bacteria can grow. So allergy can cause that inflammation. It's one of the kind of most common comorbidities of patients with sinusitis. So ask if they have allergy, if they have had any testing before, if they've had testing, what are they allergic to, have they undergone immunotherapy. And patients that have really bad sinusitis, you're going to want to be starting to manage kind of the contributing comorbidities, so allergy is one of those important things. Do they have a history of asthma? Do they, and this can kind of lead you down the pathway, do they have maybe Samper's triad, where if you see polyps on exam, they have asthma, maybe they also have allergy to NSAIDs, can kind of give you a better idea of diagnosis and treatment. Also important in that patients with asthma are more prone to developing sinusitis with polyps, so important to know if they have an asthma history. And if they don't have polyps on exam at the point that you see them, know that they are still at risk of developing polyps down the road. Have they used any nasal sprays? If so, which ones have they used? How long have they used them? Typical kind of treatment for sinusitis is going to be steroid nasal sprays like Flonase, Nasacort, those types of things. But if they're coming in and their main complaint is more of a nasal obstruction, but they think they have sinusitis and you find out they're using Afrin and they've been using Afrin for like a year, then that might change your diagnosis to more of like a rhinitis medicamentosa. So get an idea of what they're using, how long they've been using it. Again, if their main complaint is a headache, they very likely don't have sinusitis. They could have some sort of a migraine, and there's kind of a battle back and forth between uh, whether patients actually have a true sinus infection or if they have migraine. And oftentimes you have to kind of work them up and end up getting imaging to figure out that it is migraine and not actually related to sinus inflammation, but important to kind of have that in your history. And then in terms of thinking about the burden of their disease, how many times per year are they having infections, how often when they have infections are they treated with antibiotics, when they do get treated with antibiotics, do they have improvement or resolution of their symptoms with treatment or not, and this is going to give you an idea of what their diagnosis is ultimately going to be. Have they had complications from sinusitis in the past? So have they had orbital cellulitis, cavernous sinus neurosis, Pott's puffy tumor? And these diagnoses are kind of important board type questions of patient presents with this complication. Where is their sinusitis most likely located? So orbital cellulitis is typically attributed to the ethmoid sinuses, cavernous sinus thrombosis from the sphenoid sinuses, and Pott's puffy tumor from the frontal sinuses. And then finally, have they had any imaging? So before anybody's going to go to the OR, they're going to end up needing imaging. So sometimes patients will come to you from a previous or a outside ENT. Maybe they've already had imaging ordered. Maybe they come from their primary care doc and they've already had imaging ordered. But good to know if they have had imaging, because then you can take a look at that and see what they look like. So when you're doing your exam, you're going to want to look in the nose. A nasal speculum exam is going to show you some things, but probably not everything. You can sometimes see polyps just with the nasal speculum, but not always are you going to see pus, because it typically lives a little bit further posteriorly coming out of the ostia of the sinuses themselves. But you're going to be looking for polyps or pus. So an example of some pus on the right or the left coming from the maxillary os. This is a left nose. The nose on the left or the right is also a left nose, and that's a polyp. So this is a polyp that's pretty consistent with like a chronic sinusitis with nasal polyposis. It's kind of like that whitish color. You can see other polyps, and other polyps can be kind of more of the benign tumor versus malignant tumor, but they typically will have a different appearance on exam, and it's going to change your management as well. So plan, for all the kind of plans I talk about here, this is just kind of the basic bread and butter of what you should be thinking about. Certainly you're going to learn a lot more on your rotations and then through your reading. But in general, everybody with sinusitis gets sinus rinses and some steroid nasal sprays. And then important to know the definition of acute recurrent versus chronic sinusitis. So acute recurrent, 4+ episodes in a year with resolution between the episodes. If they meet that criteria of really kind of 3 episodes in 6 months or 4 episodes in 1 month, you should get some imaging. If the imaging shows an anatomic problem, they are going to be a candidate for surgery. If they get the diagnosis of acute recurrent, you should also do workup, find out if they have asthma, do they have allergies, do they have undiagnosed cystic fibrosis or something like that. And you're going to want to start to try to manage the underlying processes as well after fixing the anatomic problem, so that they don't end up getting sinus infections in the future. Chronic sinusitis then, definition, 3 months of symptoms and objective findings of sinusitis on exam. Those symptoms are primarily going to be the hallmarks of nasal obstruction, facial pressure, purulent anterior rhinorrhea, postnasal drip, not so much headache. So if they failed maximum medical therapy, which is generally saline rinses, steroid sprays, at least 2 rounds of antibiotics and a round of steroids, then you're going to need to get imaging. If the imaging shows disease, they're a candidate for surgery. You're going to end up doing surgery on whatever sinuses are affected. If the imaging shows no disease, it's probably migraine, and might be appropriate to be referred then to neurology. All right, so moving on to the head and neck side of things. So when you're working with head and neck surgeons, you're going to see a lot of new cancer. So the kind of workup for any new cancer is red flag symptoms. So in addition to, like I said, the OPQRST of how long they've been experiencing symptoms, you really want to kind of find out if they're having any of these red flags. So dysphagia, dinophagia, hemoptysis, new lump or bump, unintentional weight loss, and then otalgia as well. Otalgia, typically you'll see it in somebody who has like an oropharyngeal cancer or other cancer that has kind of migrated to the levels about 2 of the neck, because it can start to irritate the nerves and have referred pain into their ear. Do they have a history of head and neck cancer? If so, where and how was it treated? When I say where, I mean like what location of their body. Have they had a history of radiation? If yes, when? You're always, when somebody has radiation, want to know when their completion of therapy was. Whenever somebody's had previous cancer, they're going to be monitored for at least 5 years post-op to be in the before they kind of reach the cured category. So important to know how far out they are from radiation in terms of kind of managing radiation-related complications. And then also, if they've had radiation, sometimes that can lead to further cancer. So important to know when it was completed and where the radiation was done on their body. For all suspected head and neck cancers, whether they smoke, whether they drink, how long they've smoked, how much they drink, the two biggest risk factors for head and neck cancer are smoking and drinking. So if they're coming in for a new skin cancer, you're going to want to know, are they immunocompromised? So whether they've had a organ transplant, whether they have autoimmune disease and they're on meds, diabetes, not so much immunocompromised, but still good to know for potential treatment planning. So in general, basal cell carcinoma is the most common skin cancer that people get, followed by squamous cell carcinoma. But when patients are immunocompromised, squamous cell carcinoma becomes the most common. And this has treatment ramifications for patients that are immunocompromised. You're not going to be able to treat them with some of the immunotherapy that is often a good option for patients with skin cancer, and they oftentimes will need surgery to remove their cancer. And then whether or not they've had imaging or whether they had paths. So whenever you have a new head and neck cancer or suspected cancer, the kind of treatment plan you follow is first getting a diagnosis, then staging the cancer, and then coming up with a treatment plan. So imaging really kind of goes along with, it helps with diagnosis, but you need tissue in order to do that, but it's going to help with staging, and we'll talk about that a little bit more. And then path is what's going to give you the diagnosis. So if they have those things, you can start kind of moving down the pathway into getting them treated, but if you don't have those things, you're going to need to get them. So moving on to the exam, you're going to want to know your subsites of the head and neck. So I've included some of them here. I think the ones that kind of have that can be difficult to really identify. So within the oral cavity, you've got the lips, you've got the gingiva, you have the oral tongue, you have the floor of mouth, you have the retromolar trigone, which is this green area. You have the hard palate. So looking at all those subsites during your examination is going to be really important, and kind of coming up with a search pattern so that you are systematic in terms of how you evaluate your patients. With the oropharynx, you have the soft palate, you have the tonsillar pillars, you have the tonsils themselves, you have the posterior pharyngeal wall, and you have the base of tongue. So those are also going to be important areas to make sure that you're looking at systematically. And then back in the hypopharynx, you have the posterior pharyngeal wall, you have the postcricoid region, and then you have the piriform sinuses. So I always remember the hypopharynx is the PPP. All right, so when you're doing an exam, it's important to know the size of the lesion, because the size of the lesion is going to give you an idea for staging, at least from a clinical perspective. On these patients, you're going to end up getting imaging and have more accurate size as well, but kind of having a good idea of if the cancer is greater than 2 centimeters, whether or not you think that it is fixed or if it's a little bit mobile, is going to give you an idea about what the stage is going to be and how you're going to ultimately end up be needing to treat that cancer. So like I said previously, diagnose, stage, treat. So when your attending asks you for a plan, kind of the easiest thing is to figure out, do you have imaging and do you have path? If you don't have those things, you need to get them. Whenever you're getting imaging for a patient, you're going to need primary imaging and then metastatic imaging. So say somebody comes in with a oral cavity cancer, you're going to want to make sure that you get a CT scan of their neck. When you're getting a CT scan, it's always, for cancer, it's always with contrast. And then in terms of the staging, there's the T and M staging. So T, primary tumor, N, nodal involvement, and then M, whether or not there's metastases. So you need to figure out whether or not there are metastases. So generally, you're going to end up, in addition to getting the primary imaging, get a CT chest and or a PET scan. But typically, you can't get a PET scan until you have a tissue diagnosis. So in order to get tissue, sometimes you can get a tissue sample right in the office if it's like an oral cavity cancer. Sometimes patients already come in with a tissue diagnosis. But for patients that are presenting with oropharyngeal cancer, which you'll see a lot of, you're going to generally end up needing to take these patients to the OR in order to get tissue with something called a pan endoscopy. So pan endoscopy is you're doing a diagnostic laryngoscopy. You will sometimes do a nasal endoscopy. You're going to do a bronchoscopy, and then you'll sometimes do a EGD as well to look at all those sites, see if there's any cancer there. And if you see a suspicious lesion, get a tissue sample to get a better idea of where the disease is located. So after you have tissue, after you have imaging, patients become appropriate for their final staging, final clinical staging, I should say, and which point, at least at our institution, we do a tumor board, we come up with their clinical stage, we come up with a surgical plan. Resources for determining treatment I have included in the document that I made up to go along with this video. So the NCCN guidelines are going to be your best friend. In addition to, you can use the OncoAssist to get an idea of what the stage is. So once you figure out the stage, you can go to NCCN, find that stage, and then figure out the treatment plan. All right, next is something else you'll oftentimes see in head and neck clinic. So thyroids. So somebody comes in with a thyroid complaint. First question you want to answer, is it a goiter or is it a nodule? So if it's a goiter, you're generally not going to be worried so much about thyroid cancer, but kind of thinking about indications for potentially taking it out are generally going to be compressive symptoms. So is the patient having voice change? Is the patient having difficulty swallowing? If they're having difficulty swallowing, is it to solids or liquids? If somebody's having compressive symptoms from a goiter, you'd be thinking more of difficulty swallowing solids, because it's going to be a mechanical obstruction as opposed to liquids, which are typically more of a neurologic issue when people are having dysphagia there. And then whether or not they're having dyspnea. So sometimes you can have a goiter that's so big that it starts to impinge or on the trachea or move the trachea over to one side, and they can end up getting short of breath. So if it's a nodule or they're having symptoms of a functioning nodule, generally these patients are going to come from an endocrinologist. So you're going to have their TSH, you're going to have their T4 levels, and get an idea about whether or not it's functioning or not. For all patients that come in with thyroid complaints, do they have a family or personal history of thyroid cancer? Do they have a history of radiation exposure? Radiation can be a precipitating factor for patients getting a thyroid cancer. Do they have noticeable lumps and bumps in their neck? I often at times will say, do you have any lumps or bumps other than your thyroid? Usually the answer is no, but if they are feeling some other lumps and bumps, you're going to want to make sure that you examine those, because it could have lymphadenopathy and can give you an idea of that this may be a thyroid cancer as opposed to just a run-of-the-mill nodule. Like I said earlier, labs, and then do they have imaging? So typically patients will come in with a thyroid ultrasound. If they're dealing with a goiter, you might need to end up getting a CT neck to see if it's substernal or has substernal extension. But imaging is important for the workup. For your exam, you're going to want to feel the neck, feel the thyroid. If you can feel the nodule, is it firm? Is it soft? About how big is it? You'll probably end up doing you're going to want to see if there's lymphadenopathy. You're going to listen to their voice, hear if they're are having any dysphonia that you can tell. You're going to want to do potentially an ultrasound in office in order to assess their voice and their vocal cord function a little bit better. You may end up also doing a fiber optic laryngoscopy to make sure that their vocal cords are working properly. As you remember, the recurrent laryngeal nerves run right behind the thyroid, so they are at risk for damage during surgery. And want to have an idea of what their assessment looks like preoperatively. In addition, if somebody comes in and their cord's out, they have a thyroid mass, that might give you an indication that this is a thyroid cancer that has kind of invaded into the nerves of that area. So plan, if it's a nodule, you're going to want some path. If it's a goiter, no compressive symptoms, probably no surgery, but you could consider surgery if there's concern for cancer at a multinodular goiter. So as nodules get larger, you can imagine there might be, say, nodules 4 centimeters or so. There might be a little locus or focus of cancer in there that's maybe, half a centimeter. It's difficult to get a needle in that area of cancer, if there is any. So at the point that nodules get over a certain size, sometimes that's an indication for taking them out, just because you can't get a super reliable needle aspiration. So for patients with nodules, typically this is determined by the endocrinologist before they get sent into you, but for your knowledge, whether or not to biopsy is determined by radiologic criteria, so ultrasound and the TIRADS, and then whether or not to operate is dependent on biopsy results, which is called the Bethesda category. So I included those here. I included a link so that you can look at it a little bit further. Parathyroid, another complaint you will see in head and neck clinic. So remember, stones, bones, groans, psychiatric overtones, and these kind of go along with the indications for surgical management of a parathyroid adenoma. And this is going to be the questions that you're asking in your history or trying to find from the note from the endocrinologist as they come in. So calcium score greater than 1 above the normal range, history of kidney stones, bone scan showing osteoporosis. So remember, this is bone density less than 2.5 standard deviations, gives you the diagnosis. If they have a GFR less than 60, and if they are less than 50 years old, and then whether or not there's imaging done. So generally, you're going to want to do an ultrasound to see if you can see a parathyroid adenoma. Sometimes these patients will end up getting a sestamibi scan or other kind of SPECT imaging in order to localize the adenoma. So your exam is really going to be kind of the same as the thyroid exam. You're going to feel the neck. And then your plan, get imaging if you don't have it. If imaging done and it shows an adenoma, you're going to take the parathyroid out. And potentially more than one parathyroid. Sometimes it localizes to different places, and that decision is going to be dictated based on intraoperative PTH levels. All right, moving on to nasal obstruction. So this is nasal obstruction more from a facial plastics perspective as opposed to a like allergic rhinitis, sinusitis perspective. So asking the patient, which side is it harder to breathe through? Both. Does it flip back and forth? If it flips back and forth, it could be kind of related to turbinate hypertrophy. Have they had previous trauma to the nose? If so, ask when. If they have a photo prior to trauma, it's good to take a look at that as well. See if you can compare. Have they had previous surgery of their nose or sinuses? Do they use any nasal sprays? And then do they have any concerns regarding the appearance of their nose? This kind of comes into whether or not you're thinking about doing any cosmetic work as well as functional work. So on your exam, you're going to be looking for things that can cause nasal obstruction. So septal deviations, external or internal nasal valve collapse, turbinate hypertrophy. In general, when you're looking at the nose, look before you touch. You can get a lot of idea about how somebody's breathing before you end up doing the speculum exam. And I'll have some images in the following slides that show this a little bit more. Then you're going to want to do your speculum exam, see if they have any turbinate hypertrophy. You can get a better idea then, as well if what their septum's doing a little further in their nose. And then finally, the caudal or modified caudal maneuver if you're worried about internal valve collapse. So patient on the left is an example of somebody with caudal septal deviation to the left, to the right. When the septum's kind of pushed over that way caudally, oftentimes it goes the opposite direction further into the nose, but you can't necessarily tell that until you do your speculum exam. So this patient very clearly has obstruction of their nose from an anatomic standpoint, and the obstruction is really going to be affecting their internal nasal valve, but also to a certain degree their external nasal valve. So that's the pre-op photo on the left, and then on the right is the post-op photo after functional septorrhino. Patient on the right then, not quite as much of a caudal septal deviation, but still septal deviation nonetheless, more dorsally. You can tell that her nostrils are asymmetric, and probably, but based on the left, does have some narrowing of her internal nasal valve, but as you can tell, these are different types of septal deviations. So she also had a functional septal rhinoplasty, and her nose looks better. So going into here's the speculum exam, showing the internal nasal valve on the left. This septum is deviated at the caudal aspect, but not over to the other side. So this kind of goes against what I had said previously, but definitely can see that the septum's deviated, that the nasal valve is a lot smaller on the left than it is on the right. And then just wanted to kind of go over the anatomy of the internal nasal valve. So it's bounded by the lateral nasal wall, so the upper lateral cartilage here, the septal cartilage, the inferior head of the turbinate, and then the nasal floor. And then the external nasal valve is the nasal sill, the inferior aspect of the nostril here, and is in general out further than the internal nasal valve. But internal nasal valve is the most narrow part of the nose, or the nasal cavity. So when it gets even further narrowed, patients tend to have nasal obstruction. Here's an example on the left of the caudal maneuver. You will have either yourself or the patient pull on their cheeks, and it can open up their internal nasal valve. You ask them if they are having an easier time breathing when you do that. But kind of a more specific exam is the modified caudal maneuver. So you can take an instrument, in this case they're using a earwax loop, but you can just use like a Q-tip, one of the sterile Q-tips as well, and you're going to push on the area of the internal nasal valve and get an idea about whether or not they would have benefit from surgery. So nasal obstruction plan, so purely septal deviation, septoplasty. If they're having internal valve collapse, spreader grafts tend to be beneficial. I've included a picture of those up on the top right here. If they're having external valve collapse, you can use some alar batten grafts or alar rim grafts, which I've showed on the bottom right. And then if they have turbinate hypertrophy, you're going to think about doing reduction. And it can be any combination of these types of procedures. All right, next moving on to hearing loss. So first question you want to ask is it sudden or was it gradual? Is it unilateral or is it bilateral? Is it associated with tinnitus or vertigo? And then get an idea of their noise history or kind of exposure to things that could affect their hearing. So do they work in a loud environment? Do they use firearms? Have they been exposed to ototoxic meds either as a child? Have they had chemotherapy before? Have they had a history of radiation? Radiation can cause hearing loss. Have they had a history of trauma? Trauma can be you thinking more about a circular chain types of damage, and then have they had history of ear surgery? So all of these, I guess, diseases can cause a certain degree of hearing loss, but I just wanted to kind of include some otoscopic exams so we can talk a little bit more about them as well. So before I start talking about the pathology, just want to go over some of the anatomy again. So it's going to be really important on your sub-eyes to be able to identify what side of the ear you're looking at, and there are a couple of clues that you can use in order to do that. So first clue is, let's use an ear that looks a little bit more normal. So take this ear, for example, with the white arrow. You can see the malleus here. You can see the light reflex. So I always remember that the malleus points anteriorly and that the light reflex is also located anteriorly. So this means that this is a right ear. Some ears will have this little bulge in the anterior canal wall as well. So that can give you a clue as to what ear you're looking at as well. So let's start with the top left over here. So we're looking at the eardrum. The drum inferiorly looks like it's intact. We can see the light reflex, we can see the malleus, but then we see this kind of crusty material up here. So this is a cholesteatoma. So cholesteatoma typically is going to present with somebody with a chronically draining ear. They may have a history of eustachian tube dysfunction. And what happens is that the skin cells that typically form the tympanic membrane will end up getting into the middle ear space itself. And the pathophys for that is something you should read and be familiar with. And then it's not a malignant disease, but it can be locally destructive. So if this cholesteatoma continues to grow, it can start to eat away at the ossicles. It can eat away into the labyrinth. It can cause bad infections. So this is what a cholesteatoma will often look like in an adult patient. This one here, if we're looking at it, it looks like an ear, still has the light reflex. We see these bubbles, so this is a serous effusion with air fluid levels. So important to recognize this. This is, people say, oh, this is an ear infection, and it's fluid in the ear, but it's not an infection. So this patient that has fluid in their ear does not need antibiotics. They just need to, we just need to figure out a way to get the fluid out of their ear. This is also a serous effusion. So this one on the left is kind of a newer serous effusion because the fluid itself is pretty clear. If you look at this ear, the eardrum looks a little bit more gray and dull. You can still see the light reflex. This is a left ear, but you can see that there's kind of this gray. You can see some of the air fluid levels. So this is a serous effusion, but it might be kind of transitioning into a more mucoid effusion, so some thicker fluid. So this patient here looks like a pretty normal ear, and a little subtle. The arrow sign helps us figure out a little bit more about what's going on. So if you saw just this photo without a patient history, your differential would include a number of different things. When you see some red behind the ear, you might be thinking, oh, do they have a dehiscent carotid bulb? Do they have a glomus tumor? But if I tell you what the history is, it's a person with a conductive hearing loss. They have a family history of conductive hearing loss. Then it brings you a little bit more to your diagnosis of this is Schwarzschild sign for otosclerosis. So you can get redness of the promontory of the cochlea in these patients, and it's related to the spongiosis effect of otosclerosis. So this one over here is a blue ear. So whenever you see a blue ear, you should have 4 things in your differential. Or more than that even. So depending on the history. So a patient comes in after hitting their head. This could be a hemotympanum, so blood behind the ear. Other things you can be thinking about is, okay, is this a glomus tumor? Is this a carotid bulb dehiscence? Is this a jugular bulb dehiscence? Or is this a cholesterol granuloma? Bottom left, we have an eardrum. You can see it's the left ear based on where things are pointing. We can see the malleus, and then we can see the incus, or the promontory, and then we can also see part of the stapes. So this isn't a normal ear. This is an ear that has some atelectasis. So a lot of negative pressure in the ear itself from eustachian tube dysfunction oftentimes, and this person's at risk of a cholesteatoma. So what you're going to want to try to do is figure out how to get this tympanic membrane off of the structure so that you don't end up having some of the ossicles dissolve. This ear here, it's a right ear. See the light reflex, malleus. They have a little bit of an overhang on their posterior aspect of their external auditory canal. And then we see this white stuff on the tympanic membrane. So this is meringosclerosis. It's just scarring from on the tympanic membrane, potentially from tubes or other otologic surgery. This ear here, kind of an interesting angle. It's a right ear. We can see the malleus here. Looks like maybe there's some fluid behind it. But the tympanic membrane itself doesn't look to be bulging a ton. The fluid behind it seems like it's more of like a kind of amber appearance. And then we see this blister in this area. So erythematous tympanic membrane blister. So this is a bullous meningitis, so typically caused by a viral infection, but can be bacterial as well. If you're looking in a kid's ear and you see a really red eardrum, sometimes that'll be called an ear infection. Oftentimes, though, it's just because they're crying when you examine them, and it'll increase the venous pressure and make their eardrum look red. But in this case, they have a bullous meningitis from a viral infection, so would not necessarily need antibiotics for this patient. This ear, right ear, we see a little bit of meringosclerosis here, and then we see a perforation. So when you're describing perforations, you want to describe if they're central, if they're marginal, if they involve the annulus or not, and then give an idea of how much of the tympanic membrane is involved by the perforation. So I'd say this is probably like a 25% marginal perforation of the anterior inferior quadrant, not involving the annulus. And then finally on the bottom right here, this is a right ear. You can see the malleus going that way. The light reflex is gone. We can see that the eardrum's bulging. We can see that it looks really kind of white and yellow. So this is acute otitis media. So this is something that you'd have to give somebody antibiotics for. All right, let's talk a little bit more about audiograms. So you're going to be expected to read audiograms. So one of the keys to reading is kind of figuring out which one's left, which one's right. So one of the mnemonics I use is that red is round and right. So the right-sided ear is going to be red and round. So the next thing you're going to want to look at is where the lines lay in relation to the frequency curve. So I included a kind of cheat sheet for figuring out what levels of hearing loss, what levels of hearing constitute different levels of hearing loss. But in general, normal hearing in adults is a hearing level above 20 decibels. So if we're looking at this patient, they, on their left ear, have basically normal hearing in the low to high frequencies, maybe a little bit of a dip in the higher frequencies down past the 20 mark. And then on the right ear, we can see that every one of the frequencies is below the 20 hertz level. So this patient has hearing loss. In this case, we don't have bone conduction threshold, so we can't determine whether or not this is a sensorineural hearing loss or a conductive hearing loss, but they definitely have a hearing loss. This would be considered a mild loss. So generally 20 to about 40 is considered a mild. So maybe call it like a mild sloping to moderate hearing loss. And we can't say a whole lot more about whether it's sensorineural versus conductive. But sometimes audiograms, and really all audiograms, should have conductive as well. So if you see a difference between the conductive and the sensorineural greater than 10 decibels, it tells you that they have a conductive loss. And wherever the conductive loss is, tells you what they would be hearing if they didn't have that conductive loss. So sometimes you could have a mixed loss where somebody, their conductive threshold is below 20 and then their sensorineural threshold is also below 20, but there's that ear bone gap. So important to be able to describe those types of audiograms. So in this patient, they have an asymmetric loss, which means that you're going to be thinking about a wider differential on how you're going to work that patient up. You're going to see word recognition scores, so you can have asymmetric loss based on what they look like sensorineural wise, or you can have it based on their word recognition. So you could have somebody that their hearing levels look normal based on the audiogram itself, but their word recognition is different. And that's going to kind of clue you into whether or not they have a retrocochlear pathology and change your workup. So then talk a little bit more about tympanograms. So 3 types, A, B, and C. I remember B as being B flat. So A is normal. Tympanograms work by puffing some air into the eardrum after you get a seal, and it's measuring the compliance of the eardrum itself. So normal ear should have some compliance, and it should be centered around the 0 mark. B is meaning that the eardrum's not moving. So eardrum could not be moving based on a number of different factors. They could have a mass in their middle ear space. They could have a perforation of the eardrum, so it's not moving because the air just goes through it, or they could have a middle ear effusion. So that's your differential for a type B tymp. In addition to the tracing of a tympanogram, you're also going to get the volumes, so you can differentiate if somebody has a perf versus a middle ear mass versus a effusion based on the volumes. So if they have really high volumes, I think it's greater than like 2 centimeters squared, then you can probably tell just based on the temps that they have a perf, and then you'll be able to see it on the physical exam as well. So type C also has a peak, but you see that it's shifted over to the negative values. So the middle ear at baseline has negative pressure, and you use your eustachian tube in order to equalize that pressure. So if you have type C, it means that you are not able to kind of clear that negative pressure. So this person has eustachian tube dysfunction. So general plan for hearing loss: if they don't have an audiogram, get one. If they have unilateral asymmetric hearing loss, you need to be thinking about getting an MRI and thinking specifically about whether or not they have vestibular schwannoma and ruling that out. If they have a sudden loss, depending on the timing, you're going to be thinking about giving them high-dose steroids orally or intratympanic steroid injections. If they have bilateral sensorineural, consider hearing aids. If it's really bad, consider cochlear implants. Off the top of my head, I don't have the indications for cochlear implants memorized, but that's something that you'll want to look into before you start rotating with otologists. If they have sensorineural loss with vertigo, especially if it's episodic, you can start considering Meniere's disease. And if they have conductive loss, depending on where it lies on the audiogram spectrum, you could be considering otosclerosis, cholesteatoma, ossicular chain discontinuity. The differential really goes on and on. And it's kind of hard to talk about the plan for hearing loss because it all does get pretty specific. It's harder to do broad strokes. Moving on to tinnitus, so OPQRST, you want to know if it's unilateral or bilateral. Again, if it's unilateral, you might want to be thinking about getting imaging to rule out any sort of a cerebellopontine angle mass. Then you want to ask if it's objective or subjective. So subjective tinnitus is something that the patient hears but nobody else can. Objective would be something that you can actually notice. So objective, they could have a carotid bruit. They could be hearing their heartbeat. They could be hearing whooshing sounds. So one of the questions you want to ask them is like a high-pitched hum. Is it a high-pitched tone, or is it more of like a whoosh with your heartbeat? And that could give you an idea of if you're talking about subjective or objective. Other than that, you want to be asking the same questions that you'd ask for hearing loss, because oftentimes tinnitus is of the subjective variety. It's bilateral and it's related to sensorineural loss and the high frequencies. Exam. So if you're suspecting objective, you're going to want to auscultate their carotids. You're going to want to listen to the back of their neck to see if they maybe have something going on with their jugular bulb. You might want to consider imaging in the plan as well, which we'll talk about. So plan audio, if they don't have it, subjective, you can start talking to them about masking techniques, hearing aids, etc. The list of tinnitus treatments kind of goes on and on. If it's objective, kind of depending on what you're thinking about, you might order a CTA if you're thinking it's coming from their carotid arteries. Might get a CTV if you're thinking it's coming from one of the venous sinuses within the brain. You might want to get a CT T-bone if you're thinking they have a superior semicircular canal dehiscence or dehiscence somewhere else. And then can also consider an MRI. Next, dizziness, so OPQRST. The three questions you want to ask when somebody comes in with a dizzy complaint is whether or not they feel like the room's spinning around them, because this is actually vertigo, whether they feel like they're going to pass out, or if they feel like they're off balance. Patients have a notoriously hard time describing what dizzy means, so it's important to try to ask as specific of questions to nail down exactly what they're feeling. Try to feel out if there are any provoking causes of their episodes of dizziness, how long the episodes of dizziness last. So kind of top on your differential for dizziness is BPPV versus like a vestibulitis. So BPPV is going to be less than seconds. I guess Meniere's as well. It's going to be typically hours, and then vestibular neuritis, they might have vertigo for days. How often the episodes happen, whether or not there's associated hearing loss with the vertigo, if they have an associated headache, and if there was any preceding trauma. Trauma can be important if somebody's dizzy. To say they were in a car accident, then afterwards they're dizzy, but only dizzy when they like bear down or they bend over to try to pick something up. You might be thinking maybe now they have a superior semicircular canal dehiscence, which could be causing the episodic vertigo. So depending on what you're thinking about, you are going to be doing different things. So you do the Dix-Hallpike if you're suspecting BPPV. You're going to try to provoke their nystagmus in a variety of different ways. So you can do like VOR testing. You might use Frenzel lenses. If they are complaining of hearing loss, you're going to want to consider getting an audiogram. If they come in and they don't have BPPV, you can't do an Epley maneuver to fix them. You might consider balance testing. So I'm kind of bleeding into the plan part of this. So short with head turning, you're thinking BPPV, you do the Epley maneuver. If they're having hearing fluctuations during it, you're going to be thinking about Meniere's. You're going to put them on a low-salt diet, a diuretic, and then follow up with them. If they're having an associated headache, it might be vestibular migraine. Kind of the most common cause of quote-unquote dizziness in patients is vestibular migraine, not something related specifically to the ear. If the patient feels like they're passing out, it's probably not the ear. They may have something going on with their heart. And if they feel like they're off balance, the differential is really large. So I'm not going to get into that right now. Moving on to peds. So for all kids, you're going to want to know their birth history. So were they born on time? Did they ever have a NICU stay? Were they ever intubated? Now are they growing and gaining weight appropriately? So the two main complaints you're going to get in peds clinic are tubes and tonsils. So starting with tonsils, the first question you want to ask is whether or not they are concerned about infection or sleep-disordered breathing. So sleep-disordered breathing is the number one reason that ENTs take out tonsils these days. It used to be for recurrent tonsillitis. So thinking about infection, though, how many episodes of strep do they have per year? How many days of school have they missed? Have they ever had complications from strep, such as a peritonsillar abscess? Do they have any allergies to antibiotics? How many times are they getting antibiotics in a year? And there are criteria for letting you know whether or not it's appropriate to take out tonsils for recurrent tonsillitis. So then sleep disordered breathing. First question you want to ask, does the kid snore? Kid doesn't snore, probably doesn't have sleep disordered breathing. Tonsils probably are not the problem. If the kid does snore, have the parents seen them stop breathing? Is the kid difficult to wake up? Are they having trouble in school? And then have they had a sleep study before? So onto the exam, you want to look at the tonsil size. So here's some tonsil grading. In general, typically the 4+ is when the tonsils are actually touching each other, but this is a pretty good idea of you being able to determine how big the tonsils are. And then on your exam, you're going to also want to figure out if they're a mouth breather. So are they having nasal obstruction? Because that might dictate how you proceed with your plan as well. So plan, kid has big tonsils. They have a story suggestive of sleep disordered breathing. They are a candidate for tonsillectomy. Mass tonsils, so not super big, but they have a story suggestive of sleep disordered breathing, or they have a history of obesity. They have a syndrome such as like Down syndrome. They have sickle cell anemia. They have hypotonia. You're going to want to get a sleep study. So sleep study criteria for OSA in kids is an AHI of 1 to 5 is mild, 6 to 9 is moderate, greater than 10 is severe. So kid comes back after the sleep study, they're in the mild or moderate category. You can consider giving them montelukast, which can be helpful in sleep apnea in kids, but most patients aren't going to want to use it. It has a black box warning that it can cause suicidal ideation and behavioral disorders in kids. If they have moderate or severe OSA, it's an indication for tonsillectomy, and then at that point you're going to want to be thinking about, okay, were they also a mouth breather? So if they're a mouth breather, they can't breathe through their nose, you're going to want to get a lateral neck x-ray or do an endoscopy to look at their adenoid pad to see if it is infringing on the nasopharyngeal airway. If it is, you can add an adenoidectomy to the tonsillectomy. So then considerations for where that kid can have surgery. So kids with severe OSA, obesity, age less than 2, PSG showing desaturations less than 80 should be admitted overnight and observed to make sure that they're doing okay. Other kids can have surgery at an outpatient facility and go home same day. So that was all for sleep disordered breathing. For acute recurrent tonsillitis, you're going to want to be using the Paradise criteria, which I included the study for. So 7 episodes of strep in 1 year, 5 in 2 years, 5 every year for 2 years, or 3 every year for 3 years is an indication for tonsillectomy. All right, moving on to otitis media. So history, how many episodes have they had in the last 6 months to a year? How many antibiotics have they had? Have they had resolution between their episodes? Kid had previous tubes. Does the kid have a history of a developmental delay? Does the kid have allergies to antibiotics? Has the kid had complicated otitis media in the past from like a abscess or need to be hospitalized for IV antibiotics? Is the kid vaccinated? Is there smoking in the house? So the exam, you want to look in the ears, and then oftentimes you're going to want to do an audiogram. So the most common reason for tubes in kids is not so much for acute recurrent otitis media, but for chronic serous otitis media. So this is the kind of indication for acute recurrent. So if they've had 3 episodes in 6 months or 4 episodes in 12 months, it can be an indicator for tubes. Serous effusions, so not pus, but just that kind of clear fluid that we'd seen in the previous slides. So if they've had that for greater than 3 months, they come in on exam, they still have fluid in their ear, and they have had an audiogram that shows that they have a hearing loss. That's an indication for getting tubes. If the kid has had tubes previously and now needs tubes again, you're going to do tubes plus adenoids. And then if the kid is greater than 6 and they have an indication for tubes, you're going to do tubes plus adenoids. In general, you're going to have a potentially lower threshold to give kids tubes if they have developmental delay, because you're going to want to make sure that you try to preserve their hearing as much as possible. All right, moving on to laryngology. So dysphonia, OPQRST, periodicity, so whether or not their voice seems like it's worse in the morning or worse at night. How often they use their voice can give you an idea of how much their voice is bothering them. So if they're a professional like a CEO of a company, if they're a singer, they're going to have greater voice needs than others. Do they have a history of reflux? Do they have allergy? Do they have asthma? Do they have COPD? You're thinking COPD because they can be using inhalers, and those inhalers can cause some laryngitis that can affect their voice. Do they smoke? Do they drink? Dysphonia can be a presentation of cancer, so that's something you want to ask them. Have they had recent surgery or intubation? This would maybe present more with a dyspnea presentation as opposed to a dysphonia, but important for you to ask that as well. So exam, the GRBAS is a important thing that you're going to be looking at with patients to get an idea about what their voice sounds like. So it's a kind of systematic way of describing voice. Grade, roughness, breathiness, asthenia, and strain. I'm admittedly not super great at giving examples of what all of these sound like. Roughness might sound like you think the prototypical like smoker voice. Breathiness is why people talk like this. And they sound like they're whispering. Asthenia is a weak voice, so they might be just not able to really project their voice. And then strain sounds like they're really trying to get their voice out. So those are my examples. And then grade is to the degree of how rough, breathy, asthenic, or strained they are. So it's on a scale of 1 to 3, 1 being really not noticeable, 2 noticeable by a professional, and 3 noticeable to really anybody. So these patients, then you're going to do a scope. And I included some examples of scopes here, so we'll go here. So admittedly, not all of these are going to be the presentations of dysphonia, but I thought it would be a good idea to talk about some pathology too. So on the top left, this is an example of a vocal fold polyp. So it's pedunculated here. It's all on the surface of the epithelium. So this person, you can probably get surgery to take that off. This is a vocal folded cyst, so you notice it's all below the epithelium. These also you need surgery to get rid of. It's microflap surgery. So you open this up, you kind of peel out the cyst, try not to pop it, and then take it out, and then put the flaps back on the top here. Notice these two are unilateral. Over here we have bilateral. So these are vocal cord nodules. Nodules don't generally get surgery. You treat these with voice rest and voice therapy. Over on the right here, if you notice, it kind of looks like this photo, kind of looks like this photo down here. Some white stuff on the cords. You can have the patient cough to see if it goes away. This patient, that white material didn't go away, so this is leukoplakia. So it can be a precursor to a cancer of the vocal cords, so you're going to want to get a biopsy of this. Over here, you notice that this image looks kind of similar to this image. They're a little bit different. This is a vocal cord mass. So laryngeal cancer of the glottis. One of the important things you're going to want to do is get an idea about whether or not it's involving the anterior commissure, because patients that have involvement of the anterior commissure with glottic cancer have poor outcomes. So this patient's going to need to go to the OR to get a biopsy. You're going to want to look at it really closely to see if there's involvement of that anterior commissure. This image is recurrent respiratory papillomatosis, so caused by HPV, the less dangerous subtypes, so typically 6 and 11. So treatment for this varies, but in general, you're going to have to excise these out and then inject mitomycin or bevacizumab to try to control them. And the treatment gets a little bit complicated, but this is what RRP looks like, these polyps, polypoid-looking lesions. So here, this patient is currently phonating. So the vocal cords are adducting, but this is as far as they go. So you can see the vocal processes here. They're kind of making contact, but then there's this bowed out area. So this is presbylarynges. We call this glottic insufficiency, so the vocal cords don't close all the way. So this patient might present with a breathy voice. They might present with some signs of aspiration because when they go to swallow, their vocal cords aren't closing all the way. So a couple of different ways to treat this. Generally, it's with vocal fold augmentation, though. So you can inject some material into these vocal cords to kind of plump them up to get them to meet in the middle. So this patient here probably wouldn't present with dysphonia per se as much as like shortness of breath dyspnea. So here are cords here, And then in the subglottis, we see that it is pretty narrow. So this is subglottic stenosis. Kind of classic presentation of subglottic stenosis is a 40-ish year old female. She's been having shortness of breath that's been getting progressively worse for months. She's seen her pulmonologist. They called it asthma. They put her on albuterol. She's still short of breath. They eventually come to see you and they have this stenosis. So usually it's idiopathic. You end up excising it in this kind of circumferential type. You make these wedges. You dilate it. You inject some steroid or mitomycin, and you get better. But when you're seeing subglottic stenosis, you need to also be thinking about some more systemic diseases and autoimmune diseases that can present in the subglottic area. Over here on the bottom left, this patient we're looking in the postcricoid space, so here's your esophagus here. You see some kind of redness, some edema on the folds of the arytenoid here. So this is LPR. So this patient it's not GERD, it's LPR, so acid or digestive materials getting on this area, causing inflammation, and they can present with dysphonia. May or may not have symptoms of reflux, and it can be kind of difficult to treat patients with LPR because PPIs might not work super well, but that's a different lecture in and of itself. So back to this photo, some white stuff on the cords again. If you didn't know the history, you might think, oh, this is leukoplakia, but it's bilateral, so that's a little bit strange. If I told you, though, that this patient uses an inhaler or this patient's immunocompromised, you might get closer to the diagnosis. So this is a fungal laryngitis from likely Candida. And then over here, this is the same patient. So we're looking at the left vocal cord here, the right vocal cord here. This is when they're inspiring, and here's when they are trying to phonate. So you see that the right cord moves, but the left cord really stays in the same position. So this is an example of a left cord immobility. And important point to make here is that you can't make a differentiation necessarily about whether or not somebody has a paralysis versus an immobility unless you have a reason for why the nerve could be out. So if somebody's cords aren't moving super well, but there's still some movement, if you don't think it's caused by a nerve, it's called a hypomobility. If you think it is caused by a nerve, it's called paresis. And then if the nerve's not moving at all and it's not likely related to nerve, then it's called immobility. And if it is related to a nerve being out, it's paralysis. So depending on why this nerve is out, you can treat it in different ways. So I'm going to go back to the plan here. So if somebody's dysphonia is worse in the morning, gets better throughout the day, they wake up coughing at night, you want to be thinking about GERD or LPR. So in general, you're going to put that person on a PPI, and you're going to want to continue to evaluate them to see if it gets better. But treatment of LPR can be a little bit difficult. If voice is worse at night, you want to be thinking about voice use. So in general, voice rest disable, voice hygiene, get them to see SLP to see if there are ways that they can be more efficiently using their voice. Somebody has their cord out, again, it's going to depend on why their cord is out. If it's a paresis, if it's a paralysis, if it is based on a nerve, if it's just due to a neuropraxia, or if the nerve is actually cut. You can use vocal fold augmentation. Sometimes we inject a gel in. Sometimes you end up doing a thyroplasty where you put in a silastic splint when you know that that cord's going to be out permanently. But it gets a little murky, so treatment can be variable. Spasmodic dysphonia, so kind of hard to describe this over a lecture, but dysphonia is related to kind of malfunction of the muscles. You can inject Botox into those muscles. I encourage you to read more about it. Muscle tension dysphonia, in my opinion, difficult to diagnose, but in general, speech therapy, occupational therapy. Vocal cord lesion, if you suspect cancer, get biopsy and imaging. You're going to need to diagnose and stage it just like any other cancer. If nodules, speech therapy, voice rest. If it's a cyst, excise. And then finally, dysphagia, we have OPQRST. You want to ask them if they're having difficulty swallowing the solids or liquids. Like I said earlier, solid tells you it's more of a mechanical obstruction versus liquid, more of a neurologic. Are they aspirating? Have they been hospitalized for pneumonia in the past? And the way you can ask this is, do you feel like you have to cough right after you eat or drink? And then They say yes, say, do you feel like it happens with liquids? Do you feel like it happens with solids or both? They might say that they can drink water and cough, but as soon as they have like pudding, they don't cough. So that gives you an idea of kind of what their swallow function looks like. Are they having regurgitation? So do they swallow something and then it comes right back up? Do they swallow something and they feel like it gets stuck? Do they swallow something and then it comes up hours later? Do they smoke? Do they drink? Because again, you can have masses in the esophagus that could be causing dysphagia. It wouldn't even necessarily have to be in the esophagus. It could be at their glottis, and that's causing them having difficulty swallowing. Are they old? Do they have a history of neck malignancy, including like radiation? So you're going to want to scope them to see if there's anything that you can see within kind of the laryngeal inlet. Anything lower into the esophagus, you're going to need other forms of diagnostics. So that's when you'll consider a modified barium swallow study or an esophagram. So dysphagia, let me move on to this first. So on the left here, we're looking at a modified barium swallow. It's kind of inverted, so typically the barium's white, but they inverted the colors here. So you see trachea is here, here's your esophagus, and you have this big thing sticking out. So this is a cricopharyngeal bar, which generally is related to reflux. This area gets hypertrophied, it makes it difficult for them to swallow. Patients will classically describe that they swallow, they maybe have to double swallow to get food down, or they'll swallow and food will come immediately back up. So in these patients, you want to try to treat their reflux first. If that doesn't work, then you can end up Botoxing this area to get that muscle to relax. If that doesn't work, you can end up doing surgery to make a little myotomy to loosen that muscle up. Interestingly, if you're asking patients a history about this difficulty swallowing, you think it might be cricopharyngeal dysfunction, ask them if it gets better if they drink alcohol. So drinking alcohol will cause the muscle to relax and they'll be able to swallow better. All right, this patient, anterior, posterior view, and then here's the lateral view. So they've got their esophagus, which kind of takes a twisty-turny way, and then they have this outpouching here. So this is a esophageal diverticulum, and there are multiple types of esophageal diverticulum. So there's Lamer, there's Zenker's, and there is Killian-Jameson. So it all depends on where that diverticulum is coming out. Off the top of my head, I think this is a Lamer's because it's coming out laterally. But encourage you to look into all of those because I think in med school we just learned about Zenker's and there are other ones that can be caused. So with these, if they're small, asymptomatic, don't really need to do anything. But if the patient's coming to see you, it's probably bothering them, so they're going to need a surgery. And then finally, over here, we have the trachea. We see some contrast going into the trachea, so they're aspirating. And then here's where the esophagus is, and the food or liquid bolus just stops here. So this is a esophageal stenosis. You can get stenosis sometimes from like an osteophyte here. They don't have an osteophyte. But if I told you this patient's history was that they had previous head and neck cancer, they got radiated, that kind of tells you what's going on. So they have post-radiation stenosis. This patient needs to be dilated, and ENTs do the dilation. At some point, maybe it gets so bad that you can't continue to dilate it because you are going to be at risk of perfing their esophagus, giving them mediastinitis and really hurting them. So you might have to end up referring them back to a head and neck surgeon to discuss either getting a trach, and a feeding tube conduit, or a laryngectomy for non-functional larynx. So that is the plan that I just summarized in those images from before. And that's all I got here. So hopefully kind of a good high-level overview of things to be thinking about as you go on your OA rotations. Certainly not all-encompassing, but we'll give you an idea of kind of what to be thinking about of some of the more common things you're going to see and look good in front of your attendings.